Thank you. I will try to keep to 7 minutes. I've been desperately kind of striking things out as other speakers have been saying them in order to not to repeat. So I'll do my best to follow the precedent. I wanted to give a quick snapshot of what we are experiencing at the moment in terms of our own response and what as MSF we think that the priorities should be moving forward. MSF has been working with Ebola since the 1990s. Before this outbreak, we had 15 separate interventions under our belt, but I will acknowledge that this outbreak is challenging us like never before. Our response spans the 5 countries affected in West Africa, as well as an unrelated outbreak which is currently going on in DRC. As we've already heard, these are countries that are trying to rebuild after years of civil war. They already have weak healthcare infrastructure, let alone the capacity to deal with an emergency of this complexity and magnitude. You can see up here our staffing numbers. We have over 3,000 staff in the region, managing 6 Ebola treatment centers in Guinea, Liberia, and Sierra Leone. In total, we're providing, at the moment today, about 550 hospital beds. Amongst those is the biggest Ebola treatment center in the world in Monrovia at 160 beds, which is in the process of being upgraded to 200. That's not a title that we're happy to claim, would be happily outstripped in that by some of the commitments that you've heard about today. Our international president stated to the UN General Assembly several weeks ago, we are honestly at a loss as to how a single private NGO is providing the bulk of isolation units and beds. This is a question, as we've already heard from some of our other speakers, that merits some reflection, but now is not the time, only once we have the outbreak under control. And now the priority has to be just that. The calls for mobilization that we have repeatedly made have been responded to. We've heard about the commitments that are being made by member states and the UN, and we wholeheartedly welcome them. We are overwhelmed. So it means that a new phase in the Ebola response has started, and as I really emphasize, we wholeheartedly welcome that. But it needs to deliver. What does it need to deliver? The 3 West African countries that are worst affected present different characteristics, which in their response means different priorities. In Liberia, and particularly Monrovia, the situation remains acute. MSF staff have given heartbreaking accounts of the choices that they have to make between themselves and between patients, with their medical ethics colliding head first with public health considerations. Parents are forced to make devastating choices in order to prevent their entire families from becoming infected, let alone going out and finding infected people in the community. We can't accept all of those that present themselves at the doors of our treatment center because it's full. We're able to open the treatment center for 30 minutes each morning. We admit the sickest to fill the beds that have been left empty by those who died in the night. In August, I was doing interviews where I talked about our recovery rates and the importance of early treatment. But now, with the escalation of the outbreak and until the committed response for Liberia is realized, our treatment centers can't do anything other than offer palliative care. New treatment centers are required immediately, and they are in the process of being opened, but I will be honest that the safety of the care being provided in some of them raises many concerns for our teams. The importance of scaling up safely cannot be overestimated. The safety of healthcare workers and treatment centers has to be paramount. Otherwise, they risk making the situation worse, as infected healthcare workers spread the disease still further when they go home and through the mixing of healthy, suspect, and positive people. In Sierra Leone, cases presenting to our treatment centers in Kailoun and in Bo continue to rise every day. Some of them are originally coming from urban centers, as we've already heard, such as Freetown and Makeni. While support has arrived, a real increase of capacity has yet to be materialised, and we have fears that in the time it takes to safely scale up, the situation may deteriorate, and we don't know where the virus will next emerge. So this will require a great flexibility on the side of all concerned. In Guinea, although the presently available treatment centres may be sufficient today to manage the number of cases, the situation remains fragile. New cases continue to be reported from areas that have been unaffected previously, and if surveillance, contact tracing, and health education are not done in the appropriate way, the situation could quickly deteriorate again. So it is vital that we retain a context-specific approach and a community-specific approach, as already referenced by Colin, and we adapt our response according to the needs for each. But still, some common priorities remain. The first, as we've already heard from David, is that we need to scale up drastically. The isolation centres promised must be established now. It is not enough for third-party governments to build isolation centres and conduct trainings. While NGOs and local healthcare providers can manage some, third-party governments will also have to manage them themselves. The UN must coordinate and lead this effort. The second consideration is that it must be done safely. There is the very real potential to do harm in the strictest sense of the term. Treatment centres themselves can become contamination centres if protocols are not strictly applied. The third, as I've already described, is that we must retain flexibility. This is a dynamic outbreak. What is a hotspot of today might not be a hotspot of tomorrow. So we need to maintain the agility to keep up with the virus, which to date has outpaced us. The fourth consideration is that those with the capacities to contribute to the provision of general healthcare must start to do so, but in a way that is adapted for an outbreak setting. This means ensuring that health centres are equipped and organised adequately to provide general healthcare safely and to respond to what we've already heard is a crisis within a crisis. Currently, in Liberia and Sierra Leone, if you are a woman in obstructed labour in need of a cesarean, there is nowhere to go, and that has fatal consequences. And my final point is just on the need to accelerate the research and trials that are already ongoing into treatment and vaccines for Ebola. On a policy level, the lack of effective tools to treat and prevent Ebola is one more example of the barriers that exist to research and development of new treatments for infectious diseases that are most prevalent in the developing world or middle-income countries. This is not, unfortunately, unique to Ebola. But whilst we search for these new treatments, we must not lose sight of the fact that the priority is to create more treatment capacity today so that patients can be isolated and prevented from infecting other members of the community. We absolutely recognise that community approaches also need to be scaled up, but this must go hand in hand with referral centres, where we can offer a minimum of care and dignity to patients and start to reduce the fatality rate, or, put in more human terms, increase the number of survivors. One of my final photos up here is Mamadi, who was discharged from our treatment centre in Foya in Liberia on the 4th of September, one of our 650 success stories. We already heard from David that it is possible to reduce the fatality rate. In the early stages of the outbreak at one treatment centre in Guinea, we were able to reduce the fatality, this is Mamadi, we were able to reduce the fatality rate to 20% due to the incredible reception of the community and the early admission of suspected patients. But that was before we became overwhelmed with the sheer numbers. This proves that Ebola can be beaten. We can restore hope, we can restore trust within the community, but we require the political will to do so. One final point. I just want to dedicate those words to the 8 of our staff that we have lost through this Ebola outbreak. MSF has never had fatalities amongst its staff before, but given the unprecedented scale of what's happening, we've now had 8 of our staff die. They were infected in the community, but it just proves how totally vulnerable healthcare workers are, and we need them at the forefront of the fight against Ebola.
Thank you for that, Vickie.